Good afternoon, everyone. Thanks, Nikki. Thanks, Lauren, for inviting me to be here. I think this is my first TED Talk. So it's really great to see so many familiar faces, some new faces, though they might not be new. It might just be that I don't recognize you without your mask on. I know this is the last talk of the day, and genetics and hereditary syndromes is such a riveting topic. So I'll try to keep you with me on this. I was asked to speak about this because we do a lot of funky things in the GI lab. And a lot of times in the room, the nurses are sort of like, well, why are we taking 80 biopsies? Why are you doing X, Y, Z? And I thought, okay, well, why don't I just give a talk about this? And I'll just explain sort of why we do what we do for our hereditary syndrome patients relative to our endoscopy and GI practices. As you'll come to see, that simple notion didn't actually translate to such a simple talk. So I'll try to keep it high level and save a lot of time for kind of discussion and questions. So what I'd like to do today is, before we even get into the endoscopy questions, is really take a step back and say, why should we even be talking about this? Why should we care? And then we'll talk about the role of endoscopy specifically in helping take care of these patients and decrease their chance of dealing with cancer problems. So perfect. When we think about cancer, it really doesn't have to be a medical talk to know that there's a lot of different things that contribute to cancer risk, right? Family history, lifestyle, environment, genes, and the way that we kind of think about it with our patients is that it's really a combination of what we're born with and over our life periods, what we are exposed to. And all of these things kind of interact to contribute to cancer risk. Cancer really is fundamentally a genetic disease. What I mean by that is it's genetic changes in a cell that cause that cell to not work the way it's supposed to, therefore grow and move in a way it's not supposed to, and eventually turn into a tumor and a cancer. And these genetic changes are in genes that are responsible for pretty important functions. It's what we call oncogenes or tumor suppressor genes, but basically genes that are responsible for how cells move, how they divide, how they grow. And when we look at cancers, most of those tumors, if we look at those cells and look at the genetic changes in those cells, they have mutations, mistakes all over the place in these important genes. So when we think about cancer, most cancers are non-hereditary, meaning a patient's born with two normal copies of the gene. They inherit one copy from mom, one copy from dad. Life happens as time goes on, whether it's in colon tissue, stomach tissue, perhaps a mutation or a mistake happens in one copy of that gene, and they may go the rest of their lives without a second mistake happening in that remaining copy. And that one remaining copy works, it does what it's supposed to do, the patient doesn't necessarily get cancer. But if a second hit happens, usually later in life, 60s, 70s, then now you have a cell that has no working copy of whatever important gene we're talking about that regulates growth, movement. And then you've got a cell that has the predisposition to grow abnormally, move abnormally, and therefore perhaps turn into a tumor and a cancer. When we think about our genetic conditions, the folks that I take care of in our GI department here, these folks are unfortunately born with one copy down. So they actually inherit a mistake from mom or dad in whatever particular gene we're talking about. And so every cell of every organ of their body has one working copy and one not working copy. And so essentially that means that that patient sort of has a head start or is primed to developing cancer, because all it takes is one mistake in that gene, whether it's in colon tissue, uterus tissue, and then that patient is predisposed to developing cancer. So put a different way, in kind of a graphic way, everyone else born with normal cells, normal genes at birth, maybe some mistakes happen, and it might really take time and luck, bad luck, for the combination of mistakes needed to create an abnormal cell that's not working, and then potentially a cancer. For our hereditary syndrome patients, they're essentially born with a mistake in every single cell, and those same random events can happen. They just have the predisposition to happen sooner, and that patient can get cancer much earlier. So does having one of these genetic syndromes, Lynch, FAP, does that mean a patient's going to get cancer? Well, of course, it's not a foregone conclusion. Otherwise, I wouldn't be here. I'm in the prevention space, right? We'd be talking about oncology. We know that inheriting a gene is not a foregone conclusion. And this is a really, really important message for our patients. It's extremely stressful when patients learn that they have one of these hereditary syndromes. They say, well, I'll just throw in the towel, I'm going to get cancer. That's not the case. We have really, really powerful ways to prevent cancer, which we'll talk about. But of course, the same things that increase cancer risk in the general population are the ones that increase the risk of a hereditary syndrome patient getting cancer, because it's really DNA damage that leads to cancer, that second hit. So it might be carcinogens, smoking, sun exposure for the skin, hormonal reproductive issues, or just an inability in that patient to repair DNA mistakes. So not everyone with an inherited mutation, thankfully, gets cancer. So when we think about cancer, all comers, you can see I haven't labeled this as colon or gastric or uterine, because this actually kind of applies across the board. When we take most solid organ cancers, about 60 to 70% are what we call sporadic, meaning there's no family history, there's no obvious genetic condition that we can identify. And these are the common cancers that we see kind of roll through our endoscopy lab, older individuals who are diagnosed on screening or surveillance. They oftentimes happen 60s, 70s. There's really not a clear inheritance pattern on one side of the family or the other. There's no kind of clear gene that's been inherited. And family members probably have about the same risk as the general population. On the other hand, about a quarter of all cancers, breast cancer, colon, whatever you're talking about, have some familial component, meaning there's family history, but not an obvious identified genetic change. And in these individuals, there appears to be clustering on one side of the family, but they tend to be kind of older, 60s, 70s. And this could be for a variety of reasons. It could be because maybe there is something inherited and we just haven't quite figured it out yet. And it's kind of low risk stuff. It could be that there's a shared environment in family members. You know, we all kind of think about the family that shares the farm that they grew up on, and many kind of siblings, cousins develop cancer. But oftentimes it's a combination of two, kind of the shared environment as well as some shared genetics. So what about this tiny piece of the pie, 5 to 10%? Well, these folks are the folks that dominate my hereditary GI cancer practice. And these are families where we see cancer in young individuals under the age of 50, sometimes in the 20s, 30s. You see multiple consecutive generations affected by cancer. Sometimes you have patients who've had 2 cancers separated in time. And so when we think about this pie, why would we focus on 5 to 10%? Shouldn't we focus on the 90% of patients who get cancer? I'll try to convince you that it's really actually helpful to focus on these 5 to 10% and can make a big difference in our society and our patients. And the reason is because even though it's a small percentage of the pie is big, right? 150 million individuals get diagnosed with colon cancer every year. Almost 50 million die of colon cancer. And so these are common cancers, 150,000 and 50,000. These are common cancers. It's the second leading cause of cancer-related death, 4th most common cancer. And so even though it's 5 to 10%, it's 5 to 10% of a really big pie. Not only that, but we actually have really effective ways at decreasing their risk. And we're going to talk about some of this, especially specific to our GI practices. But across the spectrum, you probably overhear some of my consent conversations when patients are asking about what's new in Lynch syndrome or what's new in FAP. We have amazing prevention capabilities. Medicines, aspirin can prevent cancer in Lynch syndrome. There was recently a study that showed that starch, an intervention as simple as daily bowl of oatmeal or a banana, can decrease cancer risk in Lynch syndrome. Of course, risk reduction surgery. You know, we don't think about this too much in GI. It's a common discussion in the hereditary breast ovarian space where women think about hysterectomy, oophorectomy, mastectomy. But if you don't have an organ, you can't get cancer in it. So when we know if a patient has a hereditary predisposition to some of these conditions, we can actually recommend risk reduction surgery. Really exciting research happening in vaccines to prevent cancer. And our center will be participating in this trial to look at vaccines to prevent cancer in Lynch syndrome. And then, of course, endoscopy, which we'll talk about today, can decrease cancer risk. When we know somebody has Lynch syndrome or a hereditary syndrome, we customize their treatment. That could be their surgical treatment if they're diagnosed with a cancer, where in Lynch, we recommend taking most of the colon out because they have such a high risk of getting a second cancer. And then even for patients who have distant disease, where they might feel like, well, gosh, I have stage 4 disease. What difference could this make? Many have probably heard about really the outstanding results that we're seeing with immunotherapy, kind of a new type of chemotherapy that can really have outstanding results in microsatellite high or Lynch syndrome tumors. So we have this kind of awesome opportunity to intervene across the spectrum of cancer prevention all the way to survivorship. Not just that, but these are genetic conditions. We know how they're inherited through the family, right? And so if we identify one patient, even though our system is focused on taking care of the patient in front of us, we actually have this incredible opportunity to take care of an entire family. So these conditions, for the most part, inherited in an autosomal dominant fashion. That means first-degree family members, siblings, kids have a 50% chance of having inherited the same risk. So we can essentially march our way through the family, see who's at risk, do genetic testing, find out if they have that mutation, and really be able to institute all of these preventative and cancer risk reduction measures, not just in our patient, but every single patient in that family. So because of these reasons, I do think it's really impactful for us to focus our efforts and time on focusing on these hereditary patients. So back in the day, we could cover this in 20 to 30 minutes because it really, in the GI space, simply came down to a handful of polyposis syndromes. And those on the therapeutic side have probably worked with our therapeutic endoscopists in taking out duodenal adenomas and colon lesions, a handful of hamartomatous syndromes, then serrated polyps, and then the non-polyposis syndromes, which is basically Lynch syndrome. And that's really what we knew about genetics for decades. It's not so simple anymore. This pie actually now looks more like this, where when you do genetic testing on every colon cancer patient, 10% of patients have a genetic change, and you can see all that word salad of changes that we might be able to find. So it's not as simple as the simple polyposis or non-polyposis syndromes anymore. So in fact, not only are we dealing with Lynch and some of the polyposis syndromes, but we have all sorts of other conditions that increase risk that don't necessarily cause polyposis, a bunch more conditions that cause polyposis, and then now syndromes that we focus our attention on that increase gastric cancer risk, small bowel cancer risk, as well as pancreatic cancer risk. Don't worry, I'm not going to go through every single one of these today. So this pie, these algorithms, even though we like to teach our fellows that, we divide things in categories and thinking about it categorically, in real life, it's actually much more overlapping. And that's how we approach the care of our patients. It's not that the hereditary breast ovarian folks are in a silo and us GI folks are in a silo. We work together because there are commonly scenarios in which they have patients who have increased risk of breast cancer, but then also polyps. And so we co-manage these folks. So for our hereditary syndrome patients, we have a lot available to us to decrease their risk of cancer. Certainly, our focus today is endoscopy, but we have medicines that can decrease cancer risk, dietary and exercise interventions that have been shown to decrease risk reduction surgeries like we've talked about, and then also discussions on exposures. But our focus today will really be what our role is in the endo lab at decreasing their risk of cancer. So what I'll do today is really focus on the two main syndromes that we see, Lynch syndrome and familial polyposis. And if you have an interest in the word salad up there or see these patients come across an endo lab for the conditions that we don't cover today, there'll be plenty of time for us to review those in the future. Lynch syndrome is common. How many people have a friend or a family member who has Lynch syndrome? Raise your hand. So we have in this room for the virtual audience, 3 folks who have raised their hands, maybe 4. The prevalence that's estimated is 1 in 279 individuals. You guys, that's more common than celiac disease. That's more common than Crohn's disease. That's more common than many of the things that we think about and talk about every single day. And so the reality is probably there's only 3 or 4 people in this room that know they know someone in their friends or family circle that has Lynch, but there's many, many more of us that probably have someone that we know that they just don't know about the diagnosis yet. It accounts up to 5% of all colon cancer, so it's kind of a big chunk of that pie. And it's caused by a mutation, inheritance of a mutation, either from mom or dad, in one of 5 genes. And these genes are in a family called mismatch repair genes. And these genes, that's exactly what they do. The genetic code, as you know, is sort of our body's instruction manual that kind of instructs the cell to do what it's supposed to do. And these mismatch repair genes make a protein that fixes mistakes. So every time a cell divides, it has to duplicate the contents of that cell, right? And so this genetic code, this millions and millions of strings of genetic code has to kind of duplicate, and mistakes are bound to happen. And so when you get these random insertions of genetic code that aren't supposed to be there, these mismatch repair genes make these little proteins that fix them. They just take them out and fix that mistake. So when you have a cell with mismatch repair deficiency, a genetic change where now that protein is not there or it's not functioning properly, that genetic change gets incorporated into that cell's genetic code. So now you've got a cell that has all sorts of random insertions of code that shouldn't be there. When you can't fix mistakes, mistakes start to pile up, right? So if the fundamental defect in Lynch is that you can't go back and fix mistakes, these mistakes start to compound. And if they're mistakes in additional functions on how to fix mistakes, or functions that we've talked about how cells move, how they divide, how they grow, you can see how these things can just balloon into really abnormal cell growth. So in Lynch syndrome, these patients unfortunately have a head start to cancer. They're much more likely to get cancers at much younger ages than the general population. They can get multiple cancers, sometimes at the same time, where you see a cecal cancer and then a left-sided cancer, and those aren't related, they're not metastatic. It's that they're 2 unique independent cancers, or even cancers in different organs, where an individual is just recovering from their uterine cancer, and then we diagnose a colon cancer. They tend to occur more so in the proximal colon than the distal colon, and they have these sort of unique endoscopic and histologic features where they have sort of this inflammatory infiltrate to them. When we think about the cancer risks, this mismatch repair defect, even though we're all in GI and we focus on what we do in endoscopy and the colon and upper GI tract, this mismatch repair defect is present in every cell of every organ. And accordingly, the cancer risks, when we compare the cancer risks to the general population, are elevated across the board. So we talk about colon the most, where patients with Lynch can have an over 60% chance of getting colon cancer over their lifetime. But you can see that there's a multitude of cancers wherein Lynch patients have a much higher risk than everyone else. So what can we do about it? This is staggering, and it's really quite demoralizing to present this information to a patient. And so we quickly follow with what our interventions are to really decrease that risk. I will say that the risks that we demonstrated, not all Lynch is the same. I told you there are 5 genes that can cause Lynch syndrome if there's a mistake in them. And what we're starting to learn is that the cancer risks are customized. And so you'll see that the recommendations that we have are now customized to the gene. But in general, for Lynch syndrome, colon cancer is the top cancer that we worry about. In GI, we have this amazing opportunity with colonoscopy, right? To not only detect cancers before they develop symptoms, but to find precancerous polyps. And how satisfying is it when we're in the endo lab and are able to remove a polyp and essentially prevent that polyp from turning into cancer? Studies have shown that colonoscopy, patients with Lynch syndrome who get colonoscopy every 1 to 2 years have a significant reduction in their risk of getting colon cancer and a significant reduction in the chance of dying from colon cancer. So colonoscopy and polypectomy works. This is just really a summary of the studies that have been done since that important sentinel study back in the 90s that shows that patients who get colonoscopy every 1 to 2 years who have Lynch have an 87% reduction in the chance of getting colon cancer and a 94% chance, 94% decreased risk of dying from colon cancer. So colonoscopy is quite effective for our patients. So it's no surprise that our guidelines really reflect this. we know that earlier and intensive colonoscopy can be effective at decreasing cancer risk. And so the National Comprehensive Cancer Network summarizes this really, really nicely based on the genetic change. You can see that the genes are a little bit different in the ages at which patients get colon cancer and their overall, lifetime risk. And the key is that for the high-risk genes, MLH1 and MSH2 EpCAM, we recommend starting colonoscopy really, really young, age 20 to 25. Why is that? It's because they're sort of born with this head start to cancer, and it just takes one mistake. And so we recommend starting quite early in these high-risk patients. MSH6 and PMS2 patients, we can start a little bit later. And all of the guidelines recommend repeating colonoscopy every 1 to 2 years. That's really frequent colonoscopy, especially when we know how powerful colonoscopy is and how protective it can be in the general population, where we're now saying for your average patient who has a high quality procedure, colonoscopy can be protective out to 17 years. Why are we saying 1 to 2 years for our Lynch syndrome patients? Because it's a biologically different disease. It just takes one mistake in the wrong place and it can snowball, and a tiny polyp can develop into cancer. I was glad that you all had some questions for Katie, because even though I was told to provide my presentation ahead of time, it gave the IT folks a moment to load the presentation while she was entertaining questions. And the last addition that I put in here is actually a patient whom I scoped yesterday. And Polly, you weren't in the room with me, you were a couple doors down. But this is a Lynch syndrome patient, lovely gentleman. This was his colonoscopy in October of last year. He's traveling to England next month. And so he got into my schedule a month early because he didn't want to miss his procedure. And this is what we saw yesterday. It is entirely possible that I missed this lesion 11 months ago, but it's highly unlikely. He has MLH1 Lynch syndrome, and this is what happens. So even though colonoscopy reduces the risk of colon cancer significantly, for the folks who do get colon cancer, the mean time from a clear colonoscopy to cancer is 11.9 months. That's why we recommend this, and that's why we do this. He's going to England because look at what we did. We lopped this thing off with a hot snare. My nurse checked in on him today. He's feeling fine, and he's set to go on his trip. Humbling. What's that? That's a great question, Angie. Left colon, so I didn't clip. Yeah. So let's make our way through the rest of the GI tract for these GI patients, the Lynch syndrome patients. Many who have been in the room with me know that we oftentimes do an EGD along with the colonoscopy, and probably before I even utter it, there's going to be a bottle for H. pylori biopsies, and you don't know why, and you never know what the follow-up is on whether that's actually useful or not. So let's talk about that a little bit. Gastric cancer risk is increased compared to the general population. And this is sort of the basic kind of understanding of how we think most individuals develop gastric cancers. This is the intestinal type of gastric cancer where there can be inflammation. It then progresses to sort of atrophic or kind of burnt out changes. And then the cells start to change a little bit, called metaplasia. That can kind of transform into precancer changes or dysplasia, and then ultimately cancer. And the rationale for checking for H. pylori is that we know that H. pylori can promote inflammation as well as atrophy. And so that's the reasoning behind always checking for H. pylori and eradicating it. Now, the curious thing is, has that actually been shown in Lynch syndrome to increase risk? And are Lynch syndrome cancers progressing through the same biologic pathway? We don't know the answer to that question yet, but in the excess of caution, given the limited risk associated with gastric biopsies, our current professional societies do recommend checking for Lynch syndrome checking for H. pylori in all of our Lynch syndrome patients. So our guidelines, given reflecting that the average age of gastric cancer diagnosis is a little bit later than colon, and the risks thankfully are not as high as colon, suggests that all patients should be offered an upper endoscopy anywhere between the ages of 30 to 40, earlier if there's a family history of gastric cancer, or if there's odd findings like metaplasia or dysplasia, these kind of high risk things on that progression to cancer, and repeating that test every 2 to 4 years. So you'll often notice that sometimes the Lynch syndrome patients, we're just doing a colon, sometimes we're doing an EGD and a colon, and it's because Leslie Van Nostrand just masterfully organizes all of this for me and essentially coordinates patients' procedures based on when they're due for what. Making our way down the GI tract. Small bowel risk. And if you look at those bars, it's a little bit over 10% for kind of the higher risk genes in Lynch syndrome. We all are familiar with capsule endoscopy. So you see this capsule study on the left, and then a follow-up deep enteroscopy with Katie and colleagues who do this for us to go and find that lesion. Could this be a powerful tool for screening for small bowel cancer in Lynch? Well, you probably, for those who kind of spend time in the capsule lab, don't see a lot of capsules coming through for Lynch syndrome. And the reason is this. Number one, there's not a lot of data, but this study that took 190 patients with Lynch had all of them undergo capsule. 167 were completely normal. 23 showed something kind of funny. Of those, 6 of them were pretty small, less than a centimeter polyp type lesions. 16 were larger, greater than a centimeter. Of those 16, they only actually found something in half. So only 8 patients, they actually found something when they followed up with a deep enteroscopy. And of those, one was a tubulovillous adenoma in the duodenum, the other was a duodenal cancer. Interestingly, of the 167 patients who had a negative capsule, one patient actually developed a duodenal cancer 7 months after getting the capsule. So the lessons from this study are that number one, small bowel cancer happens, but curiously, all the cancers and precancer polyps that were found were in reach of a gastroscope. They were in the duodenum, right? We can see that during upper endoscopy. And honestly, even capsule didn't pick all of those up. And so as promising as capsule may seem, it just hasn't panned out as a successful screening tool for small bowel cancer in Lynch. And so our current recommendations are that we don't really do capsules routinely on Lynch syndrome patients, but we do recommend a upper endoscopy to not just focus on H. pylori evaluation and gastric polyps, but to go into the distal duodenum and assess for any duodenal polyps. This is kind of a really hot topic, and I don't want to spend too much time on it, but given the focus of this conference on interventional issues, a rapidly evolving area is what to do about pancreatic cancer. Pancreatic cancer is devastating, and even in the general population, we oftentimes diagnose it as very late stages. Patients have very short time to live after being diagnosed with pancreatic cancer. So is this an opportunity, especially in our high-risk patients who have an increased risk compared to the general population, to employ some of our screening modalities to find these cancers earlier? And the great news is that even though it's been fairly disappointing for a long time, more recently, studies have shown that screening can actually find cancers at an earlier stage, at a more actionable stage for specific high-risk patients. And so I think this is an area of evolving understanding. And it was just this year that the ASGE updated its guidelines on this. But I think in the Endo Lab, we're going to start seeing more and more EUSs for high-risk screening. And so you'll see patients with Peutz-Jeghers or Lynch syndrome or BRCA coming through for pancreatic screening a lot more than we have in the past. And so at present, for Lynch syndrome patients, they recommend that if a Lynch patient has a family history of pancreatic cancer, we can start pancreatic screening at age 50. It should be done at experienced high volume centers, like with our colleagues in the multi-D clinic here, Cheryl McGee, who runs that program. And you can do MRI with MRCP, alternating with endoscopic ultrasound, depending on what's available at your institution. So to summarize, I hope I've convinced you that what we do in endo for our Lynch syndrome is really, really important and impactful. Colonoscopy with complete polypectomy, popping into the small bowel, is important. It's important to keep our patients on schedule every 1 to 2 years, because even though cancer risk is significantly reduced. The ones that do happen in a very short interval. And so finding those when they're advanced adenomas, like the gentleman I scoped yesterday, or finding them when they're early stage cancers is really important. So we can't let them go beyond 2 years. Upper endoscopy every 2 to 4 years with H. pylori biopsies, pancreatic screening if a patient has a first degree relative with pancreatic cancer. And at this time, there's currently no role for small bowel capsule endoscopy. All right. We can take questions now or pause now or take questions at the end. What do you think, Nikki? Any burning questions before we shift gears and talk about polyposis? Yeah, Danny Cooper from the RMRVA. When I see That's a great question. So to repeat the question is Lynch syndrome more prevalent in certain racial subgroups? The answer is no. But what is different, as we see along the care spectrum, is disparities in access to genetic services. So white and Caucasian insured patients who have access to medical care are much more likely to be referred for genetic counseling and genetic testing. And so there have been lots of studies on this. Recently, there was a study published out of the University of Chicago that showed for all comers diagnosed with cancer, Black patients and Hispanic patients were significantly less likely to be referred for genetic testing, even meeting the exact same objective criteria as non-Hispanic whites. That's a problem. And so I think the reason we're not seeing them in our practice is not because they're not out there, it's because we're not effectively doing hereditary risk assessment and providing access to those services for those patients. But when we do, so, there have been, efforts to do universal germline genetic testing, for instance, in diverse patient populations. The prevalence is about the same, 1 in 300. When genetic services are offered in other countries, India, different African countries, the prevalence is about the same.
I have a question real quick. On the gastric cancers, I have 2 friends from college, both have suffered gastric cancer, both Black females. So I'm just wondering, is gastric cancer like the new thing now that everybody is like getting tested for? Or, I mean, because you never heard about it back in the day.
It's a great question. So not the topic of our discussion today, but you guys have heard me talk about the rising incidence of colon cancer a lot in young patients. We are actually, unfortunately, witnessing that same trend in other cancers, gastric cancer being one of them. We're diagnosing gastric cancers at much younger ages than we expected to. Now, there isn't, as far as we know, the same race disparity for Black individuals in gastric cancer as we see in colon cancer, where Black folks are diagnosed at earlier ages. Asian individuals are at higher risk for gastric cancer, but just as many of us are probably astounded by the young people that we're seeing come through with colon cancer, we're observing that trend in gastric cancer as well.
My question is just kind of out of curiosity, with the Lynch syndrome and getting approval for these procedures, someone trying to get a colonoscopy every year and an EGD every other year, do you run into a lot of issues with insurance approval?
Probably know the answer to this question. Yes, right? Like with every other issue in healthcare, but we fight. And our professional societies support intensive screening and surveillance. And sometimes I observe it sort of as a matter of who gives up first, and we're not going to give up. But there are certain insurance companies, it's insane that there's a patient that I have that comes to my mind who I scope every year, and every year her insurance company denies it. We send the same letter, just update the date, update the NCCN guideline and send it, and then they approve it. So yes, it's sort of a perpetual issue. I'm sure for folks who take care of IBD patients, particularly in the clinic, you probably run into this too in terms of procedures and their medicines. But it's one that we have by kind of scientific evidence and our guidelines to support. And so if we fight it, we have had really good success. Sometimes it's sort of on how the procedure's coded, and so there's a little bit of a learning curve. And so depending on the practice you're at, it's sort of kind of maneuvering some of those things and becoming savvy with those to try to get them through insurance a little bit easier. Oh, okay.
So similar to her question about, with the Lynch syndrome and race disparities, and are you seeing like where patients are not located near like robust medical centers, the Lynch patients are falling through and not receiving these same services and insights into their own healthcare?
Yeah, I have to admit my view is biased because I do practice at the University of Colorado. If we think about 1 in 279 or 1 in 300 patients have Lynch, individuals, 1 in 300 of the general population, they're out there, right? And just a small fraction come to medical care, period, let alone a tertiary, academic medical center. I think the first thing is that most patients with Lynch don't know they have Lynch. And so a study that was published back in 2011 estimated that only 1.2% of all Lynch syndrome patients are aware of their diagnosis. Now, that was almost a decade ago, a little over a decade ago. And so I think we're doing better now, but it's probably still less than 10% of patients with Lynch actually know they have Lynch. And so, of course, those folks are falling through the crack. And people might say, oh, gosh, that's really an unfortunate family history, or I'm so sorry you were diagnosed with cancer at a young age and it just doesn't get assessed. So I think there probably are kind of gaps in even just identifying these patients. In terms of kind of how these patients are managed, broadly, there's this unfortunate notion that genetic conditions are rare. Lynch syndrome is rare. We don't have to worry about it too much. And such a common story that patients tell me is my doctor doesn't know anything about Lynch because they say it's just super rare. It's not. Right? 1 in 300 people. It's actually more common than all of the other GI conditions for the most part that we take care of. It's more common than BRCA 1 and 2, which we hear about in the media all the time. So it's kind of a messaging issue as well, where I think, certainly from the medical provider standpoint, we have to do a much, much better job of disseminating education, providing resources to doctors to kind of be apprised of these changing guidelines year to year. But then also, I think on a public health standpoint, to get messaging out there, we need our Angelina Jolie, we need our celebrity.
I guess I'm curious, what helps guide the 1 to 2 years? If you saw a patient yesterday that went 11 months, what would cause you to push it back to 2 years?
Yeah, that was a sphincter inducing procedure yesterday. It's nerve-wracking. But generally speaking, patients under the age of 40 with no polyps and have one of those low-risk genes, MSH6 and PMS2, if they tell me, you know what, doc, I really would prefer to be on the closer side of 2 years, I think that's reasonable. For those with the high-risk genes, MLH1, MSH2, or EpCAM, or any of them that have had an adenoma, or if the prep or something about the procedure just wasn't as optimal, then I really insist on closer to 1 year. The reality, right, as we all know, is that we say 1 year, it ends up being 14 months, 16 months, and then with COVID, who knows how long, things have been delayed for certain patients. But that's kind of the rough criteria that I try to encourage patients to stick by. It's a great question. So to repeat the question, Lynch syndrome is super common. It's grossly underrecognized. What are we doing to improve screening and diagnosis of Lynch syndrome? There's a lot of different efforts underway, and we didn't talk about a lot of them today, but for decades, our approach was family history, right? I showed you those pedigrees, things that kind of fall down through the family tree, lots of cancers. What we found is that, number one, clinicians are terrible at taking multi-generation cancer family histories. Right? If you think about the few moments that we have to consent a patient in open access endoscopy, we might ask any family history of colon cancer, but we don't necessarily take the time or effort to probe more. Patients aren't as familiar with their multi-generation cancer family history. They might know if an aunt or a cousin has cancer, but they don't know what organ, they don't know how old they were, they don't know what treatment they got. And the reality is, even if we apply those family history, like perfect family history, to the criteria that we have, they actually aren't very good at picking up all Lynch syndrome patients. So for the last 2 decades, there's been a shift to say, okay, of course, we're going to still try to focus on family history and collect it, but why don't we start with the patients who have cancer and work our way backwards and say, was your cancer one of those 5 to 10% that could be Lynch? And then can we go back and track through your family and diagnose? And so that's really the main approach that we've been taking, where now universally we recommend screening all patients with colon cancer for Lynch syndrome. In fact, we also recommend screening all patients with endometrial cancer for Lynch syndrome. And we can do that by taking advantage of the biology of Lynch. I told you it's a defect in mismatch repair genes. And so essentially on the colon tumor, what the pathology lab can do is stain for the protein that fixes mistakes. And if one of those proteins is not there, MLH1, MSH2, MSA6, PMS2, then they could say, oh, is that protein not there because a lot of garbage happened in this tumor and it's a mess? Or is that protein not there because you were born with one hit and it just took a second hit and that's why it's not there in the tumor? So it's a screening test. It's not diagnostic of Lynch, but it's supposed to happen on every colon cancer. And if that testing shows, that protein's absent, that patient should be referred to genetics for genetic testing, genetic evaluation. How well do those programs work? When they're applied and there's follow through and patients kind of make their way through that system, it's very effective. The problem is certain racial ethnic subgroups don't get referred, like the testing gets done, but it just sits there and nobody follows up on it or sends them to genetics. Or for those of you who have had to deal with cancer or have family members who've dealt with cancer, probably the 10,000-foot view of why did this happen to me is not the top priority. Your priority is getting through chemo, getting a ride to your appointments, making the bills kind of connect, and another medical appointment that doesn't immediately change whether you get chemo or not, whether you need surgery or not, kind of falls to the wayside. And so the way that we've dealt with it here at the University of Colorado has been to just incorporate genetics into our multidisciplinary care for colon cancer. So if we diagnose a colon cancer in endo, I put in a referral to our multidisciplinary clinic. That patient gets seen by a clinic in one day, and they get all their appointments and their specialist appointments in one day. We're at noontime. So when I'm racing off after Wednesday endoscopy, where I'm going to colon multidisciplinary clinic. And what we do is we discuss every patient and we talk about their cancer, and the pathologist is there, the radiologist is there, the oncologist, the GI surgeon, the radiation oncologist, and a genetics person is embedded in that clinic. And for every single cancer that comes through, they say, even though everyone else is sort of focusing on what treatments do, what type of surgery, our genetic counselors will pipe in and say, guys, was anyone going to talk about the fact that this is a 38-year-old with colon cancer? And she'll do genetic counseling, genetic testing embedded into that visit. So then the patient just sees it as another thing in their panel of tests rather than a follow-up appointment. That's not really available at all institutions. We struggle with this in partnering with our affiliates, at Denver Health, where they don't have this, they don't have a genetic counselor there. They send patients to us. Our no-show rate from our Denver Health patients is high. It's like almost 50%. So there's a long ways to go, and lots of systems don't have this ability to kind of just embed it into cancer prevention care. So that's kind of a passion of mine in terms of other things that I do, research stuff, interventions to sort of improve recognition and identification of these patients.
Would you say it's worth it or a waste of resources and money for just a random person with no family history to go get genetic testing done?
It's a good question. I think I would even answer your question with a question, and that is, how prepared is that individual to deal with the results? And what context do we place those results in? So as many of you know, you could probably hop online and get comprehensive germline genetic testing for a variety of different conditions. The technology's there, it's not too financially insurmountable. But if you don't have a partner to help put that in context with what it means for you and your family, that information is only as good as sort of a curiosity. I don't think it's really, what has been examined is it cost effective if we just do population-based genetic testing? And that has not been shown to be, cost effective, but I don't think cost is the only consideration. I don't have the magic 8 ball, but I think the needle's sort of moving towards offering more comprehensive genomic services to the average individual, right? We've seen this happen in the prenatal space where, now sort of the prenatal counseling and services available is leaps beyond what it was even 10 years ago. And in the cancer space, it used to be that we would be really, really conservative. And just based on your family history, would we offer checking one gene? And if that gene was negative, maybe checking the second one, maybe the third one, and then everyone gets tired and just moves on with their lives. And now, we've seen that we can offer multi-gene panel testing. It used to be that we would only offer germline genetic testing to young patients or patients with the family history of cancer. Now that NCCN is moving towards offering germline genetic testing to everyone with colon cancer. So I wouldn't be surprised if over our lifetime that needle continues to shift to just offer the general population information. I think my caution is that that should come with resources to actually do something about it. I have a lot of patients who say, oh, my son doesn't have insurance, but I want to get him tested for Lynch. Can we just get him seen in your clinic, or can he come to my clinic appointment? Can you talk to him about it? I'm willing to pay $250 out of pocket. And I say, I'd be happy to, but what happens if he has it? How does he get that every 1 to 2 year colonoscopy? How does he get the EGD every couple of years? So our system is broken. I think if we can think about the downstream impacts, then that information can actually improve care for patients. Okay. I don't want to go over too much. I know I don't have an act to follow, but I'm sure you guys want to move on. So let's talk about polyposis. Unlike Lynch, polyposis is not subtle. How many folks have been a part of a colonoscopy where there's just been hundreds to thousands of polyps, right? Like everyone in this room. It can be overwhelming. And sometimes you don't know kind of what to do with that patient. And sometimes you see the endoscopist just rip cord out and say, oh my gosh, send them to surgery, send them to genetics. Well, let's talk about what we can do for these patients. So FAP is pretty rare. It actually accounts for less than 1% of all colon cancers. You can see the estimates far more uncommon than Lynch. Some estimates, as close as 1 in 7,000, 1 in 30,000. It's caused by an autosomal dominant mutation in this APC gene. What's really interesting about FAP is that a third of the diagnoses that we make have no family history, meaning they're de novo mutations. They started in the patient that we meet, meaning they didn't inherit a mutation from mom or dad. It started with them. And so I think this is just an important point because sometimes people say, oh, I can't have a genetic condition. I don't have family history. This is a condition that demonstrates that you don't have to have a family history. Genetic changes have to start somewhere. There's kind of different varying degrees of polyposis that we can see in FAP. And the top specimen you can see is actually a surgical resection specimen. So this classic phenotype of like thousands and thousands of polyps, patients are going to get colon cancer no matter what, is actually a pediatric disease. We inherit these patients after they've had their colectomy. And, these are colectomies that are occurring over at Children's when kids are 8, 9, 12, years old. Because if they don't get their colon out, you can't see any normal mucosa there. It's just cobblestoning of polyps. They're going to get cancer. On the adult side, it's much more common for us to see this sort of more milder or attenuated phenotype where they can have 10, hundreds of polyps. And it's really not necessarily foregone conclusion that they'll get cancer. And so you see this kind of picture below where you see a few little, lumpy, bumpy polyps, but lots of intervening normal mucosa. Polyps in FAP are really, really common. When we think about the colon, all FAP patients will have colon polyps. And depending on the severity of the polyposis, 60 to 100% of those folks will end up developing colon cancer. The second kind of most common cancer is duodenum cancer. So the first part of the small intestine, where most patients with FAP will have duodenal polyps, but thankfully only 12% or so will actually end up developing duodenal cancer. You can see that gastric polyps are super common, but gastric cancer is really rare in FAP. Similar to the distal small bowel, so beyond the duodenum, jejunum, ileum, we will commonly see polyps, but the risk of cancer kind of in the deep small bowel is quite rare. And then some of these much less common cancers, some that really are only kind of a concern in the pediatric realm. The APC gene is responsible for regulating growth. When it's not working, there's gnarly growth across the board, whether it's cancer or completely unrelated to cancer or precancer. So see, these are some of the non-cancer manifestations of FAP. These patients can get these osteomas. So you see this bump on this gentleman's forehead. These are kind of common bony growths. They're not cancer or precancer, but can be associated with this abnormal growth because of loss of APC function. You see these epidermoid cysts, as this gentleman has on the bridge of his nose. Extra teeth. So, always curious question when we ask patients if they've had to have, extra teeth pulled out as a kid or an adolescent, and then they can have these retinal abnormalities. Desmoids is another kind of major issue that deserves special attention. And it's because all of these things I told you are not cancer or precancer, but desmoids can be devastating. So desmoids are these benign kind of fibrous growths, but despite not being cancerous, they are the leading cause of death after colectomy. Risk factors include family history, being a woman, unfortunately, and then the location of the mutation on the gene. But you can see this gentleman here, this deformity on his back is from a desmoid that just would not heal despite kind of aggressive kind of rounds of different types of cytotoxic chemotherapy, did not heal. And unfortunately, he actually passed away from the desmoid and infection-related complications, not his colon cancer. So there's different ways that we can assess risk, and it's based on, as I said, the patient's sex, whether they have kind of some of these extra colonic manifestations, extra teeth, epidermoid cysts, et cetera, whether they've had a family history of desmoid problems, and then the location on the gene, and kind of assess whether they're low, moderate, or high risk for having a desmoid complication. And the reason we kind of think about this is because when you poke a desmoid with surgery, resection, it aggravates it. And so we have to think about this issue when we're thinking about what to do for their cancer risks. And so for patients that are high risk for desmoid complications, we try to kick the can down the road as far as we can in terms of surgery. So especially young women that have some of these risk factors, we try to delay surgery as much as possible because desmoid complications can be devastating for these young women. We also know that the type of surgery that we recommend in FAP can be more or less desmoidogenic. And so dissecting down into the pelvis and doing kind of a full colectomy with an ileal pouch is higher risk than just an iliosigmoid or iliorectal anastomosis. And so if we can get away with it, we try to preserve the rectum for those that have a high risk of desmoid complications. So what's the role of endoscopy? We're saying that these patients have a near 100% chance of getting colon cancer. What's the point? What can we do? Well, the role of colonoscopy is really risk assessment. So we kind of shift gears here. And many of you who scope with me know that, we'll sample a lot of these polyps, but the goal is really usually not to clear all the polyps. That's just not feasible or possible. But what we want to do is try to get a sense of how many polyps there are and kind of where they are on this pre-cancer to cancer spectrum. We know that polyps in FAP, unlike Lynch, they don't grow faster. So tiny polyps, just like in the general population, can take 10 to 15 years to grow into something serious. And so colonoscopy kind of allows us to sort of project what's going to happen with that patient and help them plan their life a little bit in terms of surgery. And so it's a really unique situation to scope this gentleman, 68-year-old, he has thousands of polyps. If you sit there and count even the ones in this picture, we probably will get to like 50, but they're all tiny, certainly less than a centimeter. Most are diminutive, less than 5 millimeters. So for a 68-year-old, for any one of these to grow, it's going to take like 10 to 15 years. So does this guy need a colectomy right away? Probably not. And if you add into certain things like our VA patients who have heart disease, are on dialysis, have kidney issues, the comorbidities would make surgery quite risky. And this might be an individual where we say, yep, you got lots of polyps. We're just going to take a look at them every year, kind of get a sense of where they are on that pre-cancer to cancer spectrum, lop off the ones that are starting to become medium to large size, and try to avoid surgery if we can. That's a totally different scenario than this young woman that I scoped a few weeks ago, 19. And these are the Goombas that we're finding in her colon. None of them are cancer. So it's not like she needs a surgery yesterday, but at 19, right, if she has these distributed throughout her colon, the likelihood of her getting cancer is very high. And despite being one of the kind of world-renowned endoscopic intervention facilities, there's no endoscopist that can do EMR of every single one of these lesions if they all kind of grow in synchrony. So for her, colonoscopy allows us to kind of get a sense of these polyps and where they are and how close they are to turning into cancer. So even though she has less polyps than that first guy who had thousands, she has hundreds of these, they're actually further along in that kind of pre-cancer to cancer spectrum. And so surgery is a little bit more pressing for her. It's not all about numbers. This patient only had 8 to 10 polyps, but look at these guys, right? This one on the right probably has carcinoma in it. If not, if we leave it in there, it's going to turn into cancer. And he has multiple, even though there's only 8 to 10 of them, multiple of these large lesions throughout. So these are knocking on the door to becoming cancer, if not cancer already. And so when we think about colonoscopy, it allows us to get a sense of where patients are on the spectrum and project to them how urgent colonoscopy or colectomy is. So when we think about colectomy, there's kind of 3 main options, right? You can take the whole colon out, do an endoleostomy. Obviously, for cosmetic reasons, quality of life reasons, that's not the ideal approach for a lot of our patients. There's the ileal pouch anal anastomosis, where you take out 99% of the colon and create a pouch from the small bowel. And then there's the ileorectum or ileosigmoid anastomosis, where you leave 5 or 10% of the colon in place and take out the majority of it. So how do you choose, or how can we guide our surgeons on which surgery is the best? And this is kind of the keen role of colonoscopy. And so if you encounter a patient with lots and lots of polyps, before you let your endoscopist rip cord out and say, oh, we got to just send this patient to John Vogel or our surgery group, it might be worth reminding them that, hey, we should kind of give them a roadmap of where all these polyps are, where the significant burden is, so they can help plan surgery. Because frequently what will happen is they'll see the surgeon will say, I'm not sure what the rectal polyp burden is. Patel, can you scope this patient and help guide, just increases another procedure for that patient. And so we, of course, consider polyp burden. We consider how many polyps are in the rectum and whether we can keep an eye on those endoscopically, and their desmoid risk, because if it's a patient with high desmoid risk and they don't have a ton of rectal polyps, well, guess what? Ileorectal anastomosis is ideal. Yeah.
Earlier, you were saying that the desmoids are benign growths. So I guess I'm just a bit confused as how that led to mortality.
Yeah, so it's really in just the terminology. So when I use the term benign here, it's really benign means not cancer, malignant means cancer. It's not to say that it's not devastating. So I think that's a good point of clarification. I'm using the term simply to delineate cancer versus not cancer, but it's certainly not indolent or non-serious. I don't mean to imply that when I use the term benign at all. Thank you. So we think about their rectal polyp burden and their desmoid risk to see if we can get away with an ileorectal anastomosis. And then lots of other things that we take into consideration: fertility, and patients' life plans. And so this 19-year-old woman, we're struggling right now because she has lots and lots of polyps, but she wants to go to school. She's in a relationship, but it's early enough that they don't really have the conversations about family planning just yet. And it's sort of accelerating all these conversations for her in a way that you can imagine most 19-year-olds are not necessarily equipped or prepared to do. But important conversations to have, because probably if she does get surgery, she has a high risk of desmoid issues. That's going to disrupt her schooling. So we have to plan around that. So for patients who have minimal rectal polyp burden, we try to preserve their rectum and decrease their risk of desmoid issues. As I said, there's other things that we take into account: their plans for family planning, how young or old they are, and then access to surveillance, which obviously shouldn't have to be an issue, but in our healthcare system it is. We have several young patients who the surgeons just decided to do a total colectomy with endoleostomy because they have no insurance. are in and out of a variety of different difficult kind of home situations, and essentially kind of made a shared decision that I don't have access to healthcare services. I don't have access to flexible sigmoidoscopy to look at the remaining rectum. I think the best thing would be to just do an end ileostomy. So we kind of have all of these conversations with our patients in a multi-D way to try to find the best surgery for the patient. But the first step is really a high quality colonoscopy to let our surgeons and our patients know what their options even are. So what about the duodenum? Thankfully, even though duodenal polyps are common, duodenal cancer is not nearly as common as colon cancer. So many of you, know that with our FAP patients, if we're doing a flex sig or a colon, we'll also do an upper endoscopy. This is usually the time when I ask you for that blue cap, and I'll show you why. So we know that many patients will have these adenomas, but only about 10 to 12% will ever end up developing cancer. We recommend starting upper endoscopies, and it's really important to visualize the ampulla. And it's because that bile is sort of a hotspot for precancer and cancer development. For many years, the standard of care was to use a side viewing scope. And so we would do an upper endoscopy and then, switch to a side viewing scope to look at the ampulla. What we now know, I think they're telling me we're done. Yeah, it might be a battery issue or something. Well, what we now know is that we don't actually have to use a side viewer. How many folks have used the distal attachment cap, that little clear plastic cap? Most, right? So this is a very easy, cheap device that you can just affix to the end of the scope, and it's used for lots of different things, but it really helps splay folds down, push things out of the way. And studies have shown that using a distal attachment cap can actually flatten out the folds in the duodenum such that you can kind of directly visualize the ampulla. And so this is really a nice feature for our patients, because then we're not switching scopes. It's nice for our endo lab because we're not processing, multiple scopes per patient for upper endoscopies. And the therapeutic endoscopists are not as upset with me because I'm not using all their duodenoscopes for my routine block when they need to be doing ERCPs. When we think about duodenal polyps, polyps are common, right? 80–90% of patients will have them, but only 10 or 12% will actually end up developing cancer. So the key with endoscopy is getting a sense of how many polyps they are and how close they are to turning into cancer. And we do that by upper endoscopy, kind of mapping out the number of polyps that we have. And then essentially based on the number, size, and histology of polyps, we can give the patient a sense of how likely they are to deal with duodenal cancer problems. So patients that have no duodenal polyps have a very, very low risk of getting duodenal cancer. They don't need another upper endoscopy for their FAP for like 4 or 5 years. Whereas patients who have multiple polyps, particularly if they're large polyps, we have this kind of classification system that sort of puts all this information together and stages those folks out. And the patients who have lots and lots of polyps, big ones, and ones that under the microscope have high-risk features like high-grade dysplasia, they have a pretty high risk of getting duodenal cancer. And those folks are the ones that really should be referred either to our colleagues at the therapeutic endoscopy group to assess whether these are amenable to endoscopic resection or potentially for surgery. But surgery in the upper GI tract is a big deal, right? Because we're talking about the ampulla. There's a lot of important things that connect to the ampulla. Pancreas ducts, bile ducts. And so this is not a simple segmental resection. It requires a Whipple. So this is a very, very important decision to contend with. Trying to remember what I was going to talk about next. I think this would be a good natural spot to pause to see if people have thoughts or questions or observations from taking care of these patients in endo and what you've seen. Yeah. Yeah.
I'm new to GI, so that's why I could ask this question. But So do we just take H. pylori biopsies in patients with symptoms? And why would we treat someone who doesn't have symptoms for it if they don't have that, like the precursor for, they don't even have gastritis, yet, that kind of thing?
Yeah, that's a great question. So there's lots of different indications to check for H. pylori. There's been studies that show, so this is just putting aside sort of even the hereditary conversation. There's studies that show that patients with symptoms such as even stomach upset or dyspepsia, treating and eradicating H. pylori can resolve those symptoms. So oftentimes for even very subtle symptoms, we'll check for H. pylori. Patients who have iron deficiency anemia, even in the absence of an ulcer, that can be predisposed by folks with H. pylori causing gastritis that may or may not be visible or obvious during endoscopy. So the indications for checking for H. pylori are kind of varied. In the hereditary space, we check for it regardless of what the stomach looks like, even if there's no gastritis whatsoever, because of this increased risk of pre-cancer to cancer transformation. And so the kind of goals of what you do about it are based on why you checked it in the first place. Now, do we do H. pylori biopsies on everyone who comes for upper endoscopy? It seems like it, right? It seems like it, but who makes their way to upper endoscopy? People who have symptoms, for something or other. And so it's probably something that, the endoscopist looked at and said, okay, you have dyspepsia or there's mild iron deficiency. Or you have GERD, but actually when you tell me about your GERD, it actually just sounds like epigastric discomfort. So that's probably why it seems like we just check them on almost everyone that comes through the door. It's because EGDs for the most part are done for diagnostic reasons. So I think with that said, I'm happy to wax poetic about hereditary syndromes as much as you all want me to, but